Hi, everybody. Welcome and thank you again for joining me. My name is Dr. Marc Liechtung, and I am ecstatic to have you join me in this adventure on Dentistry Beyond the Numbers. I think all the sessions are very important, but this is really an incredibly important aspect of dentistry. I believe this is the separator. This divides the super generalists from Main Street. And we're going to talk a lot about that separation. Today, we're going to talk about communication and treatment planning. We've talked about all the other things. We've talked about the Hamsa and the 5 most important procedures in my mind to create that super generalist. We've talked about the numbers. We've touched on various different things to make this career great and what we're searching for: a coaster, a roaster, or a rainmaker. What defines a rainmaker and differentiates a rainmaker? Somebody who's in the office, controlling the scenario, but most important, developing a trust with a patient that is second to none. Those patients that are coming to see that doctor are saying, I'm coming to see the doctor, not making a dentist appointment. They talk about them in tremendous confidence, trust, and respect. That is the difference between a clinician that can communicate and develop that trust and a doctor that comes in and does prescription dentistry. We're going to dive into this over the next 2 sessions. I'm here to express my knowledge, my confidence, to explain to the clinician that we are comprehensive, thorough, and trusting. I want to thank you again for joining me in Dentistry Beyond the Numbers, and I want to ask you, haven't asked this before, but we are growing. I want to hear your feedback. Try to be kind, but if you're not, I want to hear it also. I want to know how I'm doing for you and how I can improve. Please like me and follow me on any platform that you're listening to me. But also, I really want to know what you want to hear because I've got some great things in store. But today, we're going to embark on everything treatment plan: how to gain trust, how to present a case, and how to win that patient over for a lifetime. So thank you again, and I'm ready if you're ready. The idea of treatment planning is really expressive, explaining and communicating with the patient exactly what that patient needs. Everything we do in dentistry is custom made. No mouth is the same. So we have to, with our knowledge and our ability to explain to the patient, not only map out a plan, but develop a sequence that the patient, through layman terms, understands. Nobody wants to hear jargon and things that you need to re-explain what might be a periodontal ligament or an osteotomy. We want layman terms. My commitment to you is to give you everything I know and I have done. Because I believe that when I was practicing, we spoke about this before, I didn't do implants or root canal therapy. I had specialists in my practice at that time. But I produced over $2 million. And I often say, I like to believe what helped me the most was my communicative ability. I was able to explain to a patient and look at an 88 to 90% success treatment planning rate, which with large cases was exceptional, I'd like to believe. I'd also like to believe that once we do that, doctors are attracted to working with us, whether it be GPs, super generalists, or specialists. They know they're with a clinician that can not only diagnose, communicate, but commit patients to the treatment. The ability to gain trust is an amazing phenomenon, in my opinion. Like we're a multi-billion-dollar industry. But how do we gain trust at the chair level with our patients? We're not talking about it, clear aligners, fancy cameras, marketing techniques, better leases. Trust between me, the dentist, and Mary, my patient. I think that is the most important aspect, to be able to commit patients. We all hate that word sell. I like the word commit. I like the word commit because the patient commits to something they believe in. Our job is to allow them to learn enough to believe in us as a doctor, as a team, as an office, and as a future dentist in their lives, and hopefully many others that they may bring in. They say word of mouth is the best avenue of marketing, and I truly believe that. There are a lot less hurdles when somebody comes in and says, Joan told me you were great, than somebody that said they saw our ad in a flyer. We all know that. So let's get into it. How do we develop the trust because once you develop that trust, you have that. And that is really something special and not to be negated, not to be, forgotten about during the course of a very busy day. And I want to say that before I ever saw a treatment plan, before I ever looked at the patient and expressed to them what we're going to do, I always had a scenario that I like to believe won the trust over the patients. And I want to start with that before we get into this, because there are a lot of things to discuss and a lot of aspects to go about it, and everybody has their own magic sauce. For me, producing over $2 million with my hands, not doing any implants or root canals, I think was pretty good. So I'd like to share what I've done in the past. If we can just show the panoramic x-ray, I really appreciate it. What I used to do, and I still do, and I tell docs to do this, is to come into the hygiene room and the panoramic x-ray is up. I want you to know, don't take for granted a Panorex. 40% of the patients that come into your office may have never seen a Panorex before. And they may never have been explained anything about the panoramic x-ray. To me, you could talk CAT scans and PAs. This is the most important, and we will get into more of this. This is the most important snapshot, x-ray, whatever you call it, of our patients that could not only have patients commit, but also gain their trust. So let's go. I want to show you something. I really do. I want to explain something that I've done for so many years, and I hear it all the time. 99% of the patients have never been told this. So what I do is I go to I go into the hygiene room and I'm examining the facial structure. I'll palpate the angle of the mandible. And I'll say, Mary, you see this picture? And I will show the angle of the mandible. And I will say, you are cancer and cyst free in the bone. Has anybody ever told you that? 99%, if not more, of the patients will say, nobody has ever said that to me. Well, we look first at the catastrophic issues. We want to eliminate anything that's going on systemically. And I'm glad to tell you, you are free of cancer or cysts in the bone as far as we could see on the x-ray. That patient has just gained your office's trust through technology, communication, and ability to diagnose or not diagnose something that is paramount in their lives. This patient has now gained an incredible amount of trust and a level of feeling competent, or the level of feeling that they're in a competent set of hands and an office that could finally deliver the type of dentistry that they're seeking for so many years. I see patients in New York City come in with really bombed out mouths, neglected mouths, and I wonder, money wasn't the issue. I truly believe it's their ability to gain trust in the clinician to get over the edge. Anything that wins a little bit more trust is value. Once I do this, once I gain that trust, I could dive into a more elaborate treatment plan and really talk about the needs of the patients, sequencing and developing different phases. And we're going to talk about that. Another aspect that I see a lot of, as I am with Guardian Dentistry Partners as one of the clinical leads in the New York area for my region, I see a lot of dentist x-rays. And what I do see is not as much anymore, because we've really worked on it, but dentists that come and want to do what they really, really have their heart set on, whether it be root canals, implants, crowns. What I like to do is I call it looking left and looking right, or having some really good peripheral vision. What do I mean by that? If we could put up the second x-ray, I really would appreciate it. If we look at this x-ray, a dentist walks into the operatory and says, yes, Mary, you've got a bombed out molar. That's what's causing you pain. If you have any pain, the patient says, I don't have any pain. It's a non-vital, obviously. Well, let's treatment plan and set up for a root canal, because as you can see, and explains it perfectly. Takes a periapical x-ray. They see a little lesion forming. He or she explains that this is an infection and needs to be root canal. They ask, would you like to do it today? We'll set up for the post and core and crown next visit. That's a doctor that really is good diagnostician, good dentist, eager to do the root canal, can't wait to do the rotary, can't wait to put a crown on this tooth, maybe a distal decay on number 13. But my question to the doctor is, what about all the radiographic calculus? What about all the periopocketing? What about anything that might need to have a clean debridement post-root canal before crown and bridge? We cannot be monooptic. We cannot be staring at one aspect that we're looking to do. I met a doctor who loves to do implants. I saw her bombed outside, yet he's doing a single tooth implant with decay. And I'm saying to him, what about the other side? Well, I don't want to overbear her. I don't want to overwhelm the patient with all the treatment. That is not our job, in my opinion. Our opinion is not to cherry pick what we're going to do on the patients. Our job is, this is an exam. So a few things I want to make it clear. We are examining the patients. We are not formulating an examination for the patient to take. What does that mean? That means that I'm not a fan of multiple choice. Well, we could take the tooth out or we can do a root canal. Well, that's not the way I like to work. What I like to do is tell the patient the definitive treatment. If the patient feels that's either overwhelming, it's too costly, insurance is not working, or they have no insurance and it's a costly matter, then they want to seek a second option, that's for them to say. My opinion is not to give them three things and choose door number 1, 2, or 3. Every tooth is accounted for. We can remove that x-ray, thank you. We go through 1 to 32. I like to always start in the upper right. I start in the upper right because that's the order I go. I go 1 through 16, 17 through 32. I also talked about this from a time standpoint. Sometimes we get very, very busy and we go into the hygiene room and it's almost a pain. That is the avenue that we create our livelihood, our ability to formulate treatment plans. That is the way we do it all, right in that hygiene room. The hygienist may come in and talk about calculus. They may say you may have a cavity. That's a fine working team. I do not believe that patients have the wherewithal to make a decision that we present. They come to us for our expertise and our professionalism. Our job is to create a treatment plan that will bring them to oral health. I do not like to miss anything, because if we miss the scaling and root planing on this patient, being somebody that practiced his whole career in New York City, there is a dentist not only up the block, but could be on my floor or in the same building. Every patient that we give a diagnosis to, we must believe that there is a chance that even though we gain their trust, at some point they may say, I just have to go to a second opinion, maybe a cousin, maybe a distant relative or a friend that's finishing school and they send them x-rays. And they may say, do you see the things that are hanging off your teeth? Did they mention you need a deep cleaning? No, they just said I need a root canal. Well, I don't know. You need a deep cleaning. You need a root canal, but your gums are probably very inflamed. They never mentioned it. What trust did we build? We could tell them they're free of cancer all we want. But once we don't diagnose the proper way, or they get a second opinion to disagree with something that is there, we lost their trust. Be thorough. Be comprehensive. Diagnose what you see. Treat what you can touch. Don't believe, don't feel, don't imagine. It's there. The lucky thing about dentistry is it's black and white. So in my opinion, the one thing I've always been is comprehensive. When we get on later in the development of phases 1 and phases 2, I went to University of Pennsylvania. In the University of Pennsylvania, like many schools that are very focused on the periodontium and the supporting structures, we always had a phase 1, phase 2. Phase 1 is complete infection, decay, disease, gums, gingivitis, periodontitis, all the bad teeth. Every aspect of disease is completely cleaned up in the mouth. Deep cleanings, root canals, the crowns, the implants, the bridges, the veneers, that comes phase 2. So one little hint going forward is that we can always break it up into stages. Let's get you completely disease-free. You need a temporary, wear that for 4 or 5 months until you're ready to go on to phase 2. But these are things that we could break up down the road and explain how we sequence that. The sequencing of a comprehensive case is really the way you stay within the parameters of our plans. Because if somebody says, Doc, I want to go as slow as you can. I'm a little phobic. I don't have time. Whatever the reason they give you, the ultimate reason for me, I believe, is 2: pain and money. And pain comes in many forms. Mentally, they got to go about this. Physically, they think they're going to feel it, and they might. And money it's an expensive case. So my belief is that once we start the phase 1, phase 2 treatments, we will win them over by getting disease-free. They will say, let's finish the case. My experience is the reason they say to hold up is because what they really want to say is, can we go slow so I can get to know you a little bit? That is really paramount in what we are facing. So my point is that I don't want a patient to tell one of my clinicians or us who are listening that I don't want to go. What are you going to do? If you don't want to go to the sequence that we're talking about and the treatment plan that we presented, then what do? Do you go straight to crowns? You have to cure the disease. The gums need to be healthy. The root canals need to be done. The decay needs to be removed. My philosophy is stick to your guns, stick to your training, and it's going to be beautiful because that's the pattern that we've developed. I don't let a patient deviate my belief. If they want to do veneers before we cure the decay in the back, that's something that I would be hard pressed to do, but we could talk about that at another time. But my belief is phase 1, phase 2. So treatment planning is really a personal matter. A couple of things I really want to talk about is posture, presentation, and phonetics. What? Posture, presentation, phonetics? You see, I believe that when we walk into a room, we are the person that they've traveled for. If we walk in, stand over them, and talk loud to them, what confidence do they have in us? If I'm saying, Mary, that tooth is broken, but if I say, on their level, sit eye to eye, we've all heard this, knee to knee, we've all learned this. A couple of dental schools out there, I'm really pleased to hear, and I hear this again from my going into his 3rd-year son, that some of the schools are hiring actors and actresses to come in and get exams and have treatment plans presented by the dental students to the actors, and they critique their presentation, their confidence, their ability to communicate. It's phenomenal. I'm thinking of doing that with the doctors. It's phenomenal. You get a young actor that's as a patient or a middle-aged actor and see and grade those students, those doctors, those clinicians that want to get better at communicative treatment planning. It's amazing. But if we are phonetically equal to our patient, eye level, meaning we are not talking louder than the 82-year-old woman. We are not talking down and standing over patients. We are sitting eye to eye, knee to knee. Tonation to tonation. Patients respect that. We are more humane. We are presenting to them things that allow us to present to them in a way that's more of an equal and less of a superior structure or a superior doctor that is going to inflict a lot of treatment and they're getting nervous about it. And I know we've all heard this, but I will tell you a personal anecdote about this. I had some orthopedic surgery, and I'll never forget this. I remember the orthopedic surgeon. I went to 2 doctors. One doctor had a very nice reputation, came in, never sat down, seemed like he stood because he was rushing, stood over me and said, the surgery is going to go smooth. It's going to be no problem. We're going to be great. Let me get Shirley in the front to schedule you. Don't worry about it. Loud, over me, didn't seem to have time to answer any questions. And there I was left with his front desk, which I did not mind, but I had so many questions that they had to reschedule my appointment. Healing time, what's the pain level? So she said, if you want to wait around, we can drag him out of another room. But then I went to a different hospital. I'm going to tell you, in New York, there's an orthopedic hospital called HSS. I walked into a surgeon's office, busy. I waited about 5-10 minutes, and the surgeon came into my room. Very well-known surgeon, sat down, crossed his legs, looked at me in the eye, and said, Marc, you need surgery. It's not going to be a problem. You're going to recuperate. It's going to be great when you heal. You're going to have this amount of days in pain. We are going to control it. Then you're going to go through physical therapy. You will be fine in 4 to 6 weeks. He sat there on my level, asked me to sit in a chair. We spoke. I felt like I was in the hands of the person that was going to deliver the care that I needed. And as I left, I said to myself, I will never stand over a patient again. That doctor made me feel wonderful, made me feel like there's hope. And sure enough, he delivered it. So much so that I referred my mother, my wife, friends, because I felt like I was in competent, trusting hands just from the way he communicated. That's how it starts. We tell him something knowledgeable. As a matter of fact, when that doctor was looking at my x-rays, he told me something that was very interesting. Now, here he has a full room of patients waiting for him, checks and future exams, but he took the time to explain to me the need for the surgery, took the time to hear any questions, and that to me meant the world. And I translated that into my life, into my practice, my docs. We are doctors. We are looking to produce. We all talk about production and collection and marketing, but the ultimate goal is in that operatory. If we're not a great super generalist, then we're an average dentist looking to make a living, which is great. But I want to believe that inside of us, if we had the tools, we'd be better than we ever imagined. So, what did I do? I thought about how I presented cases to patients, and I decided that I will never speak of this experience to my doctors and explain to them why I want everyone to sit. What we learned in school or what we read in the journals, eye to eye, knee to knee, tonation to tonation, that is what I am looking for. So I broke down the treatment planning into a process of 4 steps. And what I hope today is this is just the start. We need to walk in the room. We need to greet the patient. We need to tell them something on the x-ray. Hopefully this is something that you did already in the hygiene room. They've entrusted you with them, I should say. They've gained your ability to handle their problems. They want you to fix their issues. That's how important communication is. So I broke the treatment planning process into 4 very, very important steps. And what we're going to do in our next episode is we're going to dissect these steps. We're going to go into them and talk about the importance of these steps and grow from that. And what is the term commitment really mean? Everyone has their own scenario. Oh, they committed, they signed the paper. We're going to get into what I believe is a true commitment. So what are the 4 steps? 4 steps are broken down into 1, we look at an x-ray and we talk to the patients. Remember, the same level as I'm talking to you. We explain to the patient, number 1, everything that patient needs. They may only need 3 fillings. We want to do one in an onlay. One will be an onlay, 2 will be single surface. It'll take me 5 minutes to explain to the patient. That 5 minutes gives us the ability of gaining trust down the road. Who knows what that 1 onlay, 2 fillings, or 3 fillings bring us? Number 1, we explain to the patient exactly what they need, and we're going to dissect it. 2, explain to the patient, and this is the big one, we explain to the patient what will happen if they don't do the treatment we are presenting. It could be as simple as not doing the filling, could go into a root canal. The beauty of dentistry is, what I have found through my over 30 years of experience is, every no reaction has a reaction. I'm going to say that again. Every no reaction by a patient has a reaction. How many times, doctors that are listening with some experience to them, how many times do you see a patient that comes in after a year and a half that you told to do that filling, and now they need a root canal or an extraction? Or you told them to put a bridge in. Now the teeth have drifted. It's too late. They're going to lose multiple teeth. Every no has a reaction. It's unbelievable. So if they don't do what we're suggesting to do, there's a consequence. So the second most important thing is to explain to them what will happen. What will happen if you don't clean your teeth for 3 years? You'll develop gum disease, pyorrhea, inflammation, yada, yada, yada. What happens if you don't do that cavity? The third important part is, to me, is explaining in a very calm manner how we're going to do and what entails that work. If you've treated the patient before and you did something on one side a year ago and they're coming in for a lot more work on the other side, I like to say, you remember, Mary, that filling we did on the upper right? Sure, doctor. It's the same anesthesia to do the root canal on the upper left. We're going to give you the anesthesia. You're not going to feel a thing. We're going to make sure the tooth is good and numb. We're going to open the tooth up and we're going to take out that nerve. And it's going to be fine. And remember what I told you about that orthopedic. It's going to be great. You're going to have a great result. And we're going to be here for you. And we're going to get this done. That confidence, that ability to find real comfort in your staff and you is what this is all about. Because then you have a patient, or in the business term, a patient/customer that does more than just as a customer. It's a patient for life, possibly. Another pyramid to the people that are going to come to your office through that person that's recommending you. Remember, 3 is how simple it is to do the treatment. Listen, some treatment is not so simple. We're going to have to hold their hand, and we're going to explain it to them. We're going to be honest, but it has to be done. You have an infection and the tooth is broken below bone. We have no choice but to do. And we want to be open and honest with the patient. I know if I asked you the 4th one, many of you would not get it. But to me, the 4th one, and the 4th aspect of this table of treatment planning, is to get up and go get my manager, treatment coordinator, whoever deals with finances in my practice. The last thing I want to do is deal with finance. I don't want that finance to conflict between me and the patient. Patient can ask me for a discount. I say, yes, I'm demeaning the practice. I'm taking money out of the practice's coffers because I'm sensitive and I am very empathetic to my patients. If the patient asks me for a bigger discount and I say no, then we have now this trust and this communicative spirit between the two of us that is going to be waned. And it's not going to be very long lasting if I get into the money talk. I have a lot of patients that turn to me and go, doctor, just give me an idea. I say, well, Mary, that's way over my pay grade. I don't want to talk money. I talk sequence with my treatment coordinator. I tell them what we're going to do first, but I am not discussing finances with the patient. So again, to me, that is what it's really broken down to. Every patient I see, number 1, tell them what they need. Number 2, tell them what happens if they don't do it. Number 3, Tell them how easy it is. Tell them what the sequence is. Whether it's easy or not, our ability to talk about the sequence of events that's going to take place over the next 3-4 months of treatment or 2-3 weeks of treatment develops that confidence in the patient towards us that is second to none. He or she knows what they are talking about, and she or he can take us over the finish line to get me oral health and looking great. And that's what I want. Ultimately, everybody wants white, straight teeth, healthy, white, straight teeth. And if we can describe and really project to them what this will entail, well, then get up and get the money person. Get up and get your treatment plan coordinator, because this is the form of confidence that we strive for. This is an extremely important aspect in dentistry because we can be educated to the wazoo. We know all the procedures. We're doing implants. But if we can't communicate to the patients, we're going to let a lot of dentistry. If we're not empathetic, if we don't tell them something that separates us to gain that trust, we could have a lot of patients. I'll think it over. Give me a week. Let me talk to my husband. What we're going to discuss next time I want to discuss how we can develop commitments, how we get the patient who says yes to commit to the dentistry, why we do it, from a business standpoint, how it helps the practice, from a professional and a dental standpoint, we are committing our patients in need to treatment that they really want, but they've always been either scared or scared of the money, and we need to hold their hands through it. To me, this is really an important aspect because I see many dentists just feeling that they're a little uncomfortable with this. This is the roadmap to a lot of dentistry. Remember what I said. This is the roadmap to a lot of dentistry. I want to thank you. I want to thank you so much for the reviews or the accolades I've been receiving. But please, send me what you think. Tell me if any topics perk your interest. I would love to incorporate them as we get deeper into the dental field and dentistry. And I hope that you follow me and like me on all the platforms. Please remember, we'll be here next week on Dentistry Beyond the Numbers. Thank you so much.